Good evening and welcome to our Lenten Speaker Series. My name is Caitlin Grady and I am a Community Liaison with OSPTA Home Health and Hospice and a member of Our Lady of Perpetual Help Parish. As we continue our Lenten journey, the Church invites us into deeper reflection on suffering, mortality, mercy, and hope, trusting that even in life's most difficult moments, God's grace is present and active. Tonight's reflection, Grace of the Final Journey, Faith, Hospice Care, and the Art of Dying Well, speaks beautifully to this sacred season. As Catholics, we believe that every stage of life, from its beginning to its natural end, is holy. Accompanying one another at the end of life is a profound act of love rooted in our call to uphold human dignity, offer compassion, and entrust each soul to God's mercy. We are blessed to be joined by three presenters from OSPTA Home Health and Hospice who bring faith, professional expertise, and deep compassion to their work.
Good evening, everyone. Can you hear me okay? My name is, thank you very much for inviting us to attend to speak here at your presentation here. It is a great honor to talk with you. My name is Sherry Parzinski, and I'm a registered nurse and a community liaison with OSPTA Home Health and Hospice. I have a bachelor's degree in child development and family relations from IUP. I also have an RN diploma of nursing from Shadyside Hospital. I've been a nurse for 32 years, 26 of which have been in home health. For the past 20 years, I have dedicated my service to hospice. I've been with OSPTA for 8 years. Here with me this evening is Taylor White. She is one of our hospice social workers, and Bryce Martin, one of our hospice chaplains. I've asked Bryce to lead us in prayer this evening.
I'd like to just take a moment to, if we all could, say the Lord's Prayer. Our Father, who art in heaven, hallowed be thy name. Thy kingdom come, thy will be done, on earth as it is in heaven. Give us this day our daily bread, and forgive us of our trespasses, as we forgive those who trespass against us. And lead us not into temptation, but deliver us from evil. Amen.
This evening, we are here to talk about grace, the grace of our final journey, faith, hospice care, and the art of dying well. Hospice can play a vital role in that journey. I'd like to start this evening by telling you a little bit about OSPTA. First off, OSPTA stands for Orthopedic and Sports Physical Therapy Associates, not OSPTA, which we get all the time. We are a family-owned business established by two brothers, Jim and Alan Henson. They were both physical therapists who had a commitment to serving a community in need of both orthopedic and physical therapy care. So in 1983, they established an outpatient therapy center in the Mon Valley. These outpatient services now include physical and occupational therapy, certified hand therapy, vestibular and physical therapy, balance training, and fall prevention. 20 years later, they decided to expand and establish the home health division of the company with the goal of providing personal in-home rehabilitation services to maximize a patient's functional abilities and to assist patients in achieving their health goals. Seeing a continued need for in-home health services, in 2013, OSPTA began offering hospice care to patients whose disease progression was no longer responding to treatment, and the goal was to offer end-of-life choices while providing quality care and compassion with dignity. Services offered by home health include skilled nurses and wound care nurses, physical and occupational therapy, speech therapy, home health aides, and medical social workers. In addition to these services of home health, under hospice, we also have provide chaplain, volunteer, and bereavement services. With a continued focus on meeting patients' needs at home, OSPTA began providing a palliative care program in 2025. This little company that started 43 years ago has grown to 34 outpatient locations serving southwestern Pennsylvania and northwestern West Virginia. Home Health and Hospice now provides home-based services throughout southwestern Pennsylvania. So let's talk a little bit about the history of hospice and what hospice is. Hospice originally dates back to the medieval times, where it was a place for weary travelers to find shelter and temporary respite along their journeys. Religious groups operated the shelters for travelers on religious pilgrimages, but this time passed and they began to care for the sick, hungry, and weary. The word hospice comes from the Latin word hospes, meaning host, and I should have asked you how to pronounce these words. Hospitium, meaning hospitality. My Latin's not really that good. Modern-day hospice can be traced to the Irish Sisters of Charity, who established St. Joseph's Hospice at London in 1905. However, the modern concept of hospice care, as we know, it was pioneered and defined in large part by Dame Cicely Saunders, a British physician who opened St. Christopher's Hospice in London in 1967. It is her work that the hospice philosophy of emphasizing pain and management control of symptoms rather than curative care was established. In the United States, the hospice movement started a little later than that. It was enhanced by the work of Helen Kubler-Ross, who wrote on Death and Dying in 1969. Through the efforts of many professionals and laypersons, the hospice movement continued to advance in the United States, and the first hospice program began in New Haven, Connecticut in 1974. As hospice grew, focus began to switch from institutional death to death at home. In 1982, Congress passed the Medicare Hospice Benefit, which expanded hospice care availability for Medicare-eligible population in 1986, and it became a permanent Medicare benefit. It became a permanent Medicare benefit in 1986. Hospice is such an important benefit, often underutilized, but that is changing. Today, many people are no longer going on hospice with days left to live. In 2011, 42% of deaths in the U.S. occurred while under the care of a hospice agency. Today, that number is a lot closer to 50%. All too often, people fear the word hospice. They associate hospice with death and often with having only a few days left to live. We'd like to change that impression that everybody has of that. Hospice can be involved early and provide such support to the patient and to the family. Hospice plays a vital role at the end of life and can help make that transition and journey more smooth and comforting. Death is a very normal part of life and can generate a lot of fear because of the unknown. The education and support provided by hospice professionals can help to make the unknown less frightening. Although we don't like to think about it, we are all on the journey towards death from the moment we are conceived, and it is as natural as being born. The hospice team can play a key role in improving and facilitating that journey into dying with grace and dignity. I'd like to explain the difference between palliative care and hospice care. Both are for a person who has a progressive and possibly life-limiting illness. That person may say that they want to seek curative treatment while focusing care on symptom management. Palliative care allows them to do that. The word palliate means to soothe or to relieve. If the focus is on maintaining comfort and managing symptoms without seeking curative treatment, then hospice care would be the more appropriate option. Hospice is care for those facing a life-limiting illness when the physician determines that, given the natural course of the illness, life expectancy is 6 months or less. It doesn't necessarily have to be 6 months or less, that the expected life expectancy, but a lot of times we have patients that are on hospice for much longer. It is available for those for which treatment is no longer beneficial or desired, at the time in which comfort, care, and symptom management become the primary focus of care for that person. Hospice care addresses the patient's physical, emotional, social, and spiritual needs. The hospice model of care is designed to support the terminally ill patient and their family, while a more curative approach to care is no longer possible. Hospice concentrates on managing a patient's pain and other symptoms so that that patient may live as comfortable as possible. Hospice philosophy believes that the quality of life is as important as the length of life. There are many hospice agencies. Each one is different. They all operate under the same philosophy, but they have different approaches to their care. They have different policies. Many people believe that when you elect hospice, you have to stop your medications and you're giving up, and that just simply isn't true. Most hospices allow you to continue routine medications or treatments of non-hospice related diagnoses and symptoms, and most offer antibiotic therapies when indicated. Hospice is paid for under the Medicare benefit and by most private insurances. Medicare beneficiaries pay little or nothing for hospice. Where hospice care is provided. Most often it's provided in a person's home or family member's home, but it can also be provided in a hospital, in an inpatient facility, in a nursing home, and in personal care homes. Who can benefit from hospice? I'm sorry, let me backtrack for 1 second. I'm going to go over a few of the diseases for which we take care of patients with hospice. Chronic diseases such as cancer, end-stage cardiovascular disease, end-stage pulmonary disease, senile degeneration of the brain, or Alzheimer's or dementia, end-stage renal disease, end-stage liver disease, and neurological diseases such as Parkinson's, ALS, and strokes. Indicators for hospice admission can be things such as a decline in functional status, weight loss, loss of appetite, diet changes and difficulty swallowing, recurrent infections, oxygen dependence, history of falls, decrease in cognitive status, non-healing wounds, and multiple hospitalizations and/or ER visits. The core aspects of hospice care is that it is patient and family focused. It is run by an interdisciplinary team of professionals. They provide a range of services such as case management, pharmaceuticals, medical equipment, medical supplies, volunteers, and grief support. All services are provided under the direction of a hospice medical director and/or the attending physician who certify that that patient is terminally ill and that the medical diagnosis indicates the individual's life expectancy is 6 months or less if the illness runs its normal course. The role of the hospice team. They develop the plan of care for the patient. And this is something that we do alongside the patient and the family. Everybody is involved in this plan of care. The hospice team manages pain and manages symptoms. They attend to the emotional, psychological, and spiritual aspects of dying. They teach the family how to provide care and educate on end-of-life care, advocate for the patient and for the family, and provide bereavement and counseling. I want to go into the different core members of our team. We have a registered nurse who is a case manager. They oversee the hospice team and coordinates the patient's plan of care. The role of the RN and the LPN is to help prevent and relieve pain and offer symptom management. The RN and the LPN will make certain that all necessary medical supplies and equipment are ordered and will assist in monitoring medications. Certified nursing assistants. These lovely people help with bathing, dressing, grooming, hair care, nail care, shaving, and skin care. They provide linen changes and straightening the patient's immediate surroundings. They provide comfort measures and report further needs to the RN case manager. And they also provide emotional support to the patient and the family. I find in my practice, everybody seems to get most attached to their aides. They are integral to the care that we provide. We also offer spiritual support, and at this time, I would like to have Bryce come up here and talk to you about what he does as a hospice chaplain.
Thank you. Hello, my name is Bryce Martin. I am a chaplain with OSPTA and a worship leader at my local church in Bell Vernon called Hope Church. Before becoming a chaplain, I actually worked as a nurse for about 3 years, and then was given the opportunity to begin working with OSPTA as a chaplain. I was so grateful for that opportunity because my life is deeply rooted in ministry and in reaching the spiritual needs of others by simply pointing them to Jesus. As a chaplain, my job is not to convert anyone or force my personal beliefs on others, but to meet people where they are and to love them like Jesus and make them aware of his presence. 1 Corinthians 13, 1 through 7 says, "If I speak human or angelic tongues, but do not have love, I am a noisy gong or a clanging cymbal. If I have the gift of prophecy and understand all mysteries and all knowledge, and if I have all faith so that I can move mountains but do not have love, I am nothing. And if I give away all my possessions and I give over my body in order to boast but do not have love, I gain nothing. Love is patient, love is kind, love does not envy, is not boastful, is not arrogant, is not rude or self-seeking, is not irritable, and does not keep record of wrongs. Love finds no joy in unrighteousness, but rejoices in the truth. It bears all things, believes all things, hopes all things, and endures all things." The heart of hospice care reflects exactly this. We can do all the right things, but if we lack compassion and love, it's all meaningless. As a chaplain, I have the great privilege and honor of supporting patients who are nearing the end of life. The main goal is to help those patients find comfort and meaning and peace during that time, especially in a time that's very overwhelming and uncertain. I get to listen as patients share their thoughts and fears, beliefs, experiences, all while reflecting on their lives and what lies ahead. One of the most important roles of a chaplain is simply being present, offering a calm and supportive space where patients and families can speak openly about their feelings, including grief, fear, anger, and even acceptance. As I mentioned earlier, the role is not about converting someone's faith, but about respecting each person's beliefs and values, whether they follow a specific religion or consider themselves spiritual or have no religious background at all. The goal is to show love the way Jesus loves us and to meet them where they are. If a patient wishes, I have the opportunity to pray with them, read scripture, and my personal favorite, play some gospel hymns on my guitar and sing for them. I have been blessed to help so many patients work through spiritual concerns such as unresolved relationships, feelings of guilt, the need for forgiveness, or questions about the meaning of life and death. In many cases, I have seen people find a sense of closure and peace, and for that, I'm very grateful. Just as we are there for our patients, we are also there for their families as well and their loved ones. I have the opportunity to offer guidance and comfort and a listening ear both before and after a loved one passes away. Hospice chaplains are a part of a larger care team that includes doctors, nurses, nursing assistants, social workers, and so many different moving parts, so many different roles. But together, we all focus on whole person care that addresses physical, emotional, mental, and spiritual needs. Overall, the role of a chaplain is to ensure that patients and families feel supported, respected, and not alone during one of life's most challenging moments. I'd like to share a personal story. A few months ago, about 6 months ago or so, I got the opportunity to build a meaningful relationship with a patient who suffered with MS, or suffered from MS. She was unable to speak, but she used this device that would track her eyes and her eye movements and allow her to type out words. And I remember just sitting there and I remember her sharing so much with me, her fears, her regrets, and the things that she hoped for. More than anything, she really truly wanted to be completely and totally healed. Her faith was absolutely beautiful. It really was. Even in some of the worst circumstances, she was still looking to God and finding the good in things and in God. She believed in Jesus, and I had the privilege of encouraging her and building her faith during that time and reminding her that he was always with her. Now, unfortunately, she since has passed, but before she did, I was able to fulfill a very special request. She wanted to be baptized, and she shared with me that she believes with all of her heart in Jesus Christ and always wanted to be baptized, and I had the honor and the privilege of doing that for her. And when I say I wish I could show you the look on her face and the tears of joy that she had, in that moment it was like the only thing that mattered was that she felt close with her Lord and Savior. That's the beauty of it, and that's the small part that I get to play and I get to bring. And it's truly an honor and a blessing. I want to remind each and every one of you here in this room that the mortality rate is 100%. One day, every single one of us is going to pass from this life. But the good news is, Jesus Christ conquered death, hell, and the grave. And because of him, we can live forever. So fix your eyes not on the temporary things around us, but fix it on eternal things. Do not live only for the here and now, but strive to hear the words, "Well done, good and faithful servant," just as I am striving and as so many before us have strived and achieved. Thank you so much for your time, and may God bless each and every one of you.
Good evening. So, my name is Taylor. I'm the medical social worker here with OSPTA Hospice, and like Bryce, I am another member of the support team. A little bit about my background is that I have a bachelor's degree in gerontology with a master's in social work. I started my career in hospice as the Director of Volunteer Services and then moved into the bereavement coordinator role to focus on grief counseling with families. I then briefly worked with the waiver program at UPMC before eventually returning to hospice with OSPTA as their social worker. And I feel like hospice is where I'm meant to be and really felt called to this type of work. The support that I can offer as a member of the hospice team often includes connecting families to resources such as Meals on Wheels, Life Alert, waiver programs, caregiver agencies, or often placement in the community. I can help place patients in personal care, assisted living, and skilled level communities. I can also help families navigate different programs such as the VA if their loved one is a veteran to help them get more assistance there as well. We also offer short-term respites to families that can help a lot with caregiver relief and caregiver burnout, which is a 5-day paid stay by Medicare in a skilled nursing facility. And families and patients can utilize this up to once a month. We also have a team of volunteers for additional support that I can connect our families and patients to. If volunteering with patients at the end of their life is something that you would be interested in, I have a couple flyers up here with our volunteer coordinators and information on them. And volunteering can include sitting with a patient while, their loved one runs to the store, goes to a doctor's office, things like that. It can also help with activities in maybe one of our facilities in a nursing home of some degree, or it can help by making small gifts for our patients, such as crocheting a blanket. I also assist in end-of-life planning and helping with what's called advance directives. An example of an advance directive can be a living will, a power of attorney, or what we call our 5 wishes. So the 5 wishes is a document that talks about what you may want in the event that you can no longer make decisions for yourself. The 5 wishes, unlike a power of attorney form, it does not need notarized. So you usually just need about, 2 witnesses to sign off on this form to actually make it official. And I have a few copies up here as well. If you guys are interested, don't have any other forms of advance directives, or think maybe a loved one could benefit from it. It can also be a good use of a conversation starter because, these are the hard conversations, but I think it really is, I definitely encourage people to have them with their loved ones, whether they're sick or not at the current time. These conversations can include, do you want CPR? Do you want to remain on a vent for a long period of time? Do you want to be kept in a coma for a long period of time? And these are the difficult topics that we often have with our families, and I encourage you to have with one another, even with yourself. I actually have one of these filled out in my home, and my family knows exactly where to find it in the event that anything should happen to me. The power of attorney form I can also assist with, and this comes into play when a person can no longer make medical and or financial decisions for themselves. Like I said earlier, it does need notarized, but luckily our team has a notary on our staff. She comes out to anywhere the patient might call home, whether that be their personal home, a nursing facility, or a personal care, or even the hospital. I can also help you plan at the end of life for funeral arrangements and preferences there that can even range upwards to body donations. Additionally, I can assist patients and family in therapeutic interventions by working on coping techniques as they navigate their diagnosis or their loved one's care. I'm here to support not only the patient, but their support system as a whole. This can be through talk therapy or connecting to outside resources such as therapists. As the patient's condition worsens, my visits often increase just to make sure everybody's doing okay, monitor for family needs, and kind of hopefully minimize any effects of any abnormal grief. It's an honor to be a part of someone's journey, and we often at this point want to concentrate on the quality of their days rather than the quantity. I surprisingly probably have a lot more positive memories from working in this job than most people would think, and a recent memory that I wanted to share as well was about a patient's birthday. He has since passed, but we were lucky enough to actually celebrate his 104th birthday party together. And he was not always the happiest guy, and his family didn't live close, and we jokingly referred to him as Cranky Uncle Bill, but he was actually great, and we were able to set up a day where his family came in. We got balloons, I got cupcakes with 104 on them. We took pictures, and he got to kind of have those in his final days, especially when he was doing well. And unfortunately, he has since passed, but our team often attends funerals or memorial services for our patients, and we actually saw the picture of our team with him, with his 104 cake on one of the picture boards at his memorial service, and it just meant so much to us that we were able to make a day feel so special to him. And so many people think that hospice means you only have days left, and sometimes that's the case, but it also means that you have an entire support system and an entire support team behind you, no matter how many days those might be. So if you have any questions for me about either of these things, like I said, I have some copies up here, and yeah, that's me. Thank you so much.
Some additional services that are provided under the hospice benefit. We do have volunteers. They are trained volunteers to help provide companionship and support to patients and families, provide non-medical services, provide respites for the family and the caregivers, and support at the time of death and bereavement. It is very important for caregivers to make sure that they take care of themselves and take time to themselves, and often our volunteers can offer a respite and sit with the patient while the family member gets to go out and do something for themselves. Bereavement support, finally, is support may be initiated at any time during the course of the patient's terminal illness and continues for 13 months following death. So there are times that we identify a need earlier on than the patient passes, and we will initiate our bereavement support services at that time. And again, as the patient passes, we continue on for 13 months. That takes the family and the caregiver through all those first birthdays without them, those first Christmas, the first Easter, the first, the first birthday, anything, all of those first, it kind of really helps guide the families through that grieving process. And although generally it's 13 months, it can continue on as long as the need is there. Contact is made with additional support and is determined how the family is coping with loss. Our bereavement support program can help connect families to services that are available, such as support groups, classes, and grief counseling. While there is clearly physical symptoms that are associated when entering the final stages of life, of a life-limiting illness, experiencing one's mortality is a multifaceted and complex experience that only happens once in your life. Hospice provides end-of-life experts that can help guide a patient and their family along this journey. An interdisciplinary approach to care is mandated in hospice. All team members, including the patient and the family, play a critical role in the development and implementation of that plan of care. In summary, hospice can be very beneficial to both the patient and the family and our caregivers. With the support of hospice professionals, we are able to help our patients and our families navigate through the rough terrain of a terminal diagnosis. We are able to lighten the load a little and help our clients along their journey to die well while supporting their families and caregivers. No one needs to be alone in this journey. We can help to make those difficult goodbyes a little bit less difficult. Thank you all for your attention. We're going to open this up now if you have any questions or concerns, any personal experiences. Nobody? Yes? Yes. Generally, you have to have the person's primary physician and our hospice medical director. They basically certify that given the normal disease progression, that is without any interventions, any aggressive treatments, just say for cancer, for instance, given the normal progression, it is expected that within 6 months that person may no longer be with us. That is not getting any treatment such as chemotherapies and radiation therapies and things like that. But that does not mean that at the end of 6 months we say, oh, well, you're done. There's multiple hospice benefits. I didn't get into all that technical stuff, but as a clinical team, the nurses, the aides, the chaplains, social workers, we all communicate regularly. We actually have meetings with our medical director every 2 weeks, and we discuss our patients' care almost on a daily basis. And we are looking to see that they are still appropriate for the hospice benefit service. So if they continue to be appropriate, basically if they're showing decline, say they're having some weight loss, they're sleeping more, having difficulty swallowing, we look at all of these things. And if these things are occurring, we can say, we can continue on with these services. So we can recertify and continue. And we can do that, we do that for a period of time, and then at 6 months, we have to have a doctor or a nurse practitioner come out and actually do a hands-on physical assessment of that patient. So that they are certifying that, yes, they are still appropriate, they are still declining. And then that occurs every 60 days after that. So, so basically, you're looking, they need to be at a state where you would say, I wouldn't be surprised if they weren't here with us in 6 months. But that doesn't mean that, it's a contract you're signing. So. And then also too, if you can choose to elect the hospice benefit, and if it doesn't fit you, you can also go off of it. It's not like something that when you sign up for hospice, that's it. It's all said and done. Under Medicare, we have like Medicare A and B, which is for our regular hospitalizations and our regular home visits. But whenever somebody does elect to go on to hospice, they elect their hospice benefit. So we sign on to that and we provide care, and that continues on until that patient decides they no longer want the care or they pass away.
Or could it also be considered palliative that a person could be on hospice and getting radiation?
You got that right, yes. Generally, I mean, we have to look at what the goal of the radiation treatment. Usually the radiation treatment is palliative or comfort. So if it is something that is maintaining, like managing a tumor size so that the patient can breathe better or they're having less pain, then yes, they can certainly continue on with that. Yes.
And are there also hospice services available for children?
There are. We do not provide them, but there are hospice agencies that do provide hospice care. They're very few and far between, but they are. Yeah. I have a background in child development. I always wanted to work with children. I could never do that. I just, a lot of people ask me how I can even do work on hospice, and I find it very fulfilling. You develop relationships with the patients and with the families, and you become a part of their family. And it's encouraging whenever somebody passes away, and maybe you've been with them on that whole journey, where initially the family was very reluctant to let go. The patient may be saying, I'm done, I don't want to fight anymore, I don't want to go back to the hospital, and the family, or you have one member of the family that still wants aggressive treatment, and to see them through that process and to educate them. And when the patient finally passes, they understand that that was their call and it was right for them. It's very fulfilling. Yes, you're welcome. Good. That is a wonderful thing to hear. And, if you share that with people that you talk to, because a lot of people think it's a horrible thing, I know one time I was in the VA clinic and I was sitting next to a gentleman and I was waiting to meet with a doctor and he's like, "Oh, where are you from?" And I said, "Well, I work for hospice." "Oh, that's terrible. Everybody dies on hospice." I'm like, well, yeah, we all are dying. It's not, and not everybody that actually does die, because we actually do discharge people. We actually have patients that start to thrive and they do better. And we have to discharge them because they're no longer declining. So, and it's not a bad thing, ever. Anybody, and thank you for your comment. Anybody else? Yes? The question was, I think, about how we interface with Medicare and go according to their guidelines. We do have to follow Medicare guidelines. They have strict guidelines, and that is really to prevent fraud. And I know that we've been hearing a lot about fraud in the news lately. There are agencies out there that are a little subpar and they do not follow the guidelines like they should, or they find ways around it. But most hospice agencies are very up to par, and they are very stringent with following the guidelines that Medicare sets forth. That is actually why we have to have a nurse or a physician come out and see the patient after 6 months, and then every 60 days following. That was a requirement that was started by Medicare, so that we couldn't be continuing on with patients who are no longer declining, but we're just continuing to see them just because they're on hospice service. But everything that we do goes to Medicare. Like, they know what we're doing, they review. We get paid based on what we're doing for the patients. The Medicare benefit also not only pays for our services, for our interdisciplinary team, but they also pay for any medications that are related to the hospice diagnosis, and for medications related to comfort care, which be pain management, nausea, anxiety, things like that, things that are going to maintain that patient's comfort. Hospice does pay for. They also pay for medical equipment if a patient needs to have a hospital bed, a bedside table, a bedside commode, all those things. That is all paid for Medicare. We manage all of that. We get whatever the patient needs, but that is all paid for under Medicare. So they do watch us very closely, because they don't want to be paying for stuff that they shouldn't be paying for. I'm not sure how what's going on in California, how they're doing what they're doing. They've obviously, people know how to go through the system and avoid it, but yeah, most hospice agencies are very up to par, and we follow what the guidelines are. Actually, the guidelines are very strict, and if we have a patient that is not on the Medicare benefit, but maybe is on a private paid hospice, we still follow the Medicare guidelines because they're so strict. Yes? We like to leave that up to the primary physician and to the patient. My belief has always been that primary physician knows that person better than anybody else. So for our medical director to take over everything, and they've never even seen this patient, I think who knows best than their primary care physician. Sometimes physicians will still want to follow up on the care, but they may leave symptom management up to the hospice team because that's what they specialize in. So the primary care physician can be very much involved. Some primary physicians say once they put somebody on hospice, they don't want to be involved at all. Not that often, but sometimes they do. And with our physicians we do send them updates. So even if they don't want involved in the care, they still know what's going on. Generally it is, yeah. Yeah, because actually hospice is available 24 hours a day, 7 days a week. We have a nurse available all the time. It's our agency and any other hospice agency. So if there is a problem that occurs at 3 o'clock in the morning, the families are instructed to call hospice. We don't want you going to the hospital because usually once somebody has elected the hospice benefit, they no longer want to go to the hospital. So they are instructed that they need to call hospice, and we will send a nurse out and they can assess and see what's going on. So when they assess and they see what's going on, generally, like our hospice physicians answer their calls 24 hours a day, fortunately. So we get to wake them up at 3 o'clock in the morning, and a lot of times you can't reach a primary physician at that time. Yes? Oh, sure. Very good point. I didn't want to get too technical. I didn't know where we were going here. So, pain management. Generally, whenever we're managing patient pain in a home setting or in a facility, we're giving oral medications. Generally, that is morphine. And a lot of people get very frightened by the word morphine, almost as frightened as they are the word hospice. It is nothing to be afraid of. Morphine has been around forever. They've used it in wars. That is the first line of pain medication management. So we use primarily morphine unless somebody has an allergy to that. But the doses that we give are given orally. They're given through the mouth. They can swallow or sometimes just put them inside their cheek, and it just gets absorbed into the system. They're a low dose. It's not something that you give a dose of morphine and somebody's going to die right then and there. That's a lot of people are afraid. I've had nurses in facilities who did not want to give morphine because the patient is lying in pain and writhing, and they don't want to give morphine because they don't want to give that medicine that's going to kill them. I don't think I've ever, in the 20 years I've been working in hospice, had somebody that was not actually actively dying and actually receiving morphine routinely, that, they haven't died from getting morphine. Morphine is a wonderful medication. It's used for pain management. It's also used for shortness of breath. We use it a lot for people to manage their respirations. If somebody is breathing too fast, it helps them to slow down their breathing and for each breath to be a little bit more efficient. So we are not giving. I think a lot of people associate whenever somebody goes in the hospital and they go on hospice and they're on a morphine drip and they're on a morphine drip until they pass away. Generally, that is not the case. We really don't even use IV medications through your intravenous area. Most everything we use is oral, and it is nothing to cause or to hasten somebody's passing, but it is to manage their symptoms, to manage their pain, to manage their breathing. And there's other medications too we use, such as Ativan, which helps with anxiety when somebody's getting very near that end of life. they have a lot going on, and they need these medications in order to help to calm them and relax them. We have patients that they start to hallucinate, and I don't know that hallucinations are not necessarily, I don't think always hallucinations. They start to see and talk to people that have passed on before them, and I'll actually find a lot of comfort in that. They have somebody there that's guiding them home. But no, we do not use pain medications as a form of euthanasia. It is not something that is legal in Pennsylvania. It's that assisted suicide, I guess is what it's called. But we do not do that. Purely for comfort. Yes.
They still have that lollipops that they can't swallow.
Lollipop? No.
That they make like a lollipop.
Yeah, no, we don't. That sounds good. No, we do not. Yeah, we do not use those anymore. Basically, the morphine that we give, it's a concentrated. It's only in drops, and it's like 5 milligrams. It's not much at all. It's given, every hour as needed. And but no, we don't. And we have somebody that we're worried about managing pain more closely. They may be getting something more long-acting. They may have like a patch, like a fentanyl patch or something like that. But when we're looking at those acute instances, we're doing these medications. Like morphine is very effective. It's very fast-acting. It's not weight-based. So you can give the same dose to somebody who is skin and bones and somebody who's 300 pounds. I think it's fast-acting, and we give it about every hour as needed because it's a short-acting medication.
Now, in your practice, because of the types of drugs that are left in the home, have you ever run into a problem with control of these medications?
Oh, yeah. Yeah. We do. Our nurses do keep tabs on those medications. And we're talking about the medications that we do have in the home. We also leave it up to the families if they want to have. It's called a comfort kit, and it contains about 6 medications that are used for that what if needed. And sometimes families don't want to have it in there. We have to work on them to get them to accept having that medication in. But I really encourage families to let these medications be in the home, because if you have the problem at 3 o'clock in the morning, you have something available to give them. But we do. We don't keep a whole lot of medications in. We limit it to like a week's supply. And if we do see an issue, it's even less time than that. So we very closely monitor that. Fortunately, that doesn't happen that often. But it does happen. It does. It does. Now, the morphine that we use is actually a little bit bitter tasting, and I think they do that to deter people from using it, although I know some drug it doesn't matter. But yeah, we do. We have to watch that some. Yeah. You're welcome. Anybody else? Yes.
Just sort of a personal experience with hospice. My husband was in a nursing home. He was bedridden, and he was on a feeding tube.
Mm-hmm.
And the staff did what they could, because they were busy with a lot of patients. But I always knew when the hospice person would come in, because my husband would be shaved. Everything would be perfect when they were in.
Mm-hmm.
And then when the minister came, they would sit down, and my husband wasn't voting, but he knew what was going on.
Mm-hmm.
The pastor would listen to me, talk with me, and listen to reminiscing,
Yes.
and close with prayer. It was just
Mm-hmm.
something that the hospice not only did for my husband, it
Did
did
for you.
And on the day that he really changed and they knew that death was imminent,
Mm-hmm.
social worker was with me. She spread the day by taking the feeding tube out. She was there to help me with that.
Mm-hmm.
And even afterwards, I would get a call after 3 months. I got a call. 6 months, I got a call. In 1 year anniversary, I got a card from the hospice. So it's just not the patient, it's the people with the patient that benefit from it.
I couldn't agree more, and that's what I think is so fabulous about this hospice benefit and providing hospice care. It is not just the patient. It is the family. It is the caregiver. Everybody is involved in this journey. And sometimes, like I said earlier, sometimes the family needs it more than the patient actually does. But it involves everybody, and you're reaching out to family members who maybe have, drifted away, and you need to have that come back to have that closure. It is not just the patient and what their physical needs are and maintaining their comfort and their physical needs. It's all about caring for everybody that is loved and cared for by that patient. He was. Yeah, so there's a testimony that you can, we look very closely. We monitor our patients regularly, making sure that, they are, at any time that they're not meeting the criteria to be on hospice, we will discharge. We have to notify the family. We give the family 48 hours notice. They can also appeal if they feel, and we've actually had patients that have been on for over a year, and we've said, we have to stop. We cannot no longer be. And the family will actually appeal in all of their chart, all the Medicare reviews, all that information. Sometimes Medicare will say, no, they're okay, stay on. Sometimes Medicare will agree with us and say, no, we have to stop. But you can definitely be on for more than 6 months. I think a lot of people think, 6 months, that's all I have left. And it might be 6 months, and as Taylor said earlier, it might be days, it might be a year, but the important thing is that we're helping to make whatever time is left more important and more valuable and cherished by that patient and that family. It's about the quality of that time that's left. Yes. I'm sorry, behind you. And that's pretty much the way, I'm sorry, do you have anything else to add to that? If somebody comes to us electing the hospice benefit and they already have a feeding tube, that can continue on. We don't stop that. If they happen to be on hospice and then the family says, they're not eating much, I want to go and put a feeding tube in, that's considered an aggressive treatment. So then they would have to go off of hospice to have that service provided. But yes, that definitely, they can come onto hospice with a feeding tube, and we do continue that. And we continue that as long as that patient is able to maintain and is comfortable with that. Once you start getting to those final days in that decline, the body starts to shut down. The body doesn't take in you look at it as almost if somebody was actually eating or drinking on their own. They do stop eating as much and they stop drinking. Their body is already shutting down, and the body's sending out signals to their brain that they doesn't need the food and the water like it used to, because it is preparing to go through that journey. So if somebody does have a tube feeding, that would be something that would be a decision made between the family members, and looking at, and it's each individual patient too, each case is different. But if it gets to be the point where it's becoming it's overloading that person and it's making them uncomfortable, then we talk about stopping that.
If the tube becomes clogged, it has to be replaced.
Well, generally, a lot of times we can open it back up out in the field. We have measures to do that. But we can send them back into the hospital to have that opened up, as long as that tube's in there. If they go to a hospital, it needs to be somebody that we're contracted with, or we work a contract with them to have that taken care of, but it's still okay. We can take care of that. That's a tough decision. Yeah. Yeah, fortunately, she was able to give you that direction and let you know what she wanted. Yeah. Yeah, but hospice would not say, we're going to stop this. We're not going to do this anymore. They would go and talk to the family and educate the family and let them know the pros and the cons, and and what we're looking at and what's going to make the best quality of life for their family member. We make that choice that way. You had a question?
Yes, when the person actually does pass away at home, is the hospice nurse permitted to come out to pronounce them?
Yes. I'm sorry, I had to think there for a second, because each county's different, and we service like 6 different counties. So certain counties require an RN, and I think Allegheny County is one of them. So an RN, and that is actually what we instruct our families, that whenever the patient does pass away, that they call us first. Because we have to come out, we have to make that pronouncement, we have to contact the coroner and let them know that that person has passed away. Then we continue on and make all the other necessary calls. We'll call the funeral home to have them come and release their loved one into the funeral home's care. But we make all those, and then call the physicians and all that. We make all those necessary calls. But yes, anytime on hospice. And if somebody is on hospice, then the coroner does not need to be involved. And the coroner does not have to start a case or come out or do anything like that. We just contact the coroner. They'll say, we'll explain the patients on hospice. Generally, they'll ask what they were on for or how long. And they say, okay, you can release to the funeral home. So, any death, the coroner has to be hauled, no matter what, whether it's in a facility or a home. But yeah, if it's at home, we do have to notify them. Anyone else? Some really great questions and comments from everybody. I'm glad some of you have had experiences, and they've been good experiences. Anyone else? Well, I thank you so much. Did you have any questions for the chaplain or our social worker? Thank you all so much for coming out this evening. It has been an honor to share our evening with you guys. Hopefully let you know a little bit more about how going through that journey into death doesn't have to be scary, and that there's support out there. There's people available to help guide and help support you through that journey, whether it's for a family member or it's for somebody that that is in need. A lot of people know people, and they say they're just really struggling. Mention it. Mention hospice. Don't be afraid to say say, hospice might be something that you want to look into. It might really help support and provide you with a little bit extra that you need. Thank you all so much.